better expand them, but that data is still not clear. So if they have a 19 surgical valve, valve is not a good bailout. So if someone, and that has changed our surgeons' mentality. So if someone's having a surgical AVR, we try and encourage them to put at least a 23, because that gives us opportunities for valve as a bailout. There are also new surgical valves. The Inspirus valve from Edwards has the surgical valve design is such that it accommodates valve therapy by expanding. The frame expands actually. So we're starting to look at this. So you have to think about what your expectations are for gradients, because patient prosthesis mismatch is a real concern. And when you look at this study, this graph from the Vivid Registry, when you look at mortality, in patients with a less than 21 or less, the mortality was 4 times higher than those with a 25 millimeter valve. So this patient prosthesis mismatch leads to worse outcomes, and we've seen that in the surgical literature. And then beyond these high residual gradients, there's concern for leaflet thrombosis. You can see this with a 4D CT, but this is an explant, and you see all this thickening and leaflet thrombosis. And one reason you may get that, this is from Dr. Yoganathan at Georgia Tech, but see, look at when this valve is not able to expand, you're going to get pinwheel. You're going to get stasis of flow. You're going to get leaflet dysfunction. This valve is not opening normally. You're going to get poor hemodynamics. So when you undersize a sapien in a surgical valve, you may get this, or a core valve, you may get this. And this is going to lead to early leaflet failure and leaflet thrombosis. This is a little bit more optimal. This is our stretch leaflet. So the reality is, in terms of durability, we need to collect more rigorous long-term data for valve and valve. There aren't going to be randomized trials. It's going to be our responsibility to collect that data. Another expanding indication is bicuspid valves. And the challenge with bicuspid valves is they're asymmetric. You see here, this is a type 1 bicuspid, and they're typically very large annuli. But there are varying types. This one is a type 1, and that's most often what we see, but there are also type 0 bicuspids without the raphe as well. The question in a bicuspid is, are you going to seal at the leaflet level, or are you sealing below at the annulus? Because if this raphe doesn't crack, the valve will seal here, and so you may size it differently, where you're looking at that dimension. But the valves are often associated with aortic root pathology, with annular dilatation and aortic dilatation. And how you manage that is relevant. And they often have very bulky calcium. And the reason that's relevant is when you have a raphe that's very bulky here, the valve will not be allowed to expand in this direction. So it's only going to expand in this direction. And we've done cases where you see the bicuspid valve sits like this. It does not expand in the other direction. And that increases the risk for root injury, in this particular case, under the left main, under the left coronary cusp, because there's no room for it to expand. So you have to be aware of these risks when you're treating these patients. There have been results with both balloon expandable, self-expanding. Some people have said Lotus has an advantage. How you size, these are all unanswered questions in these patients. But this is an example. This video is not playing, but here it is. You see this leaflet, this was a bicuspid valve, type 1 that we did. We got a little bit of ellipticity, and this leaflet is not opening. So this leaflet is going to guarantee you're going to thrombose without anticoagulation. We've also got abnormal hemodynamics there. There is very limited data. This is the largest series. And what we've seen is the annual rupture risks were higher with balloon expandable, but the PVL rates were higher with core valve. Newer generation with Evolut and Sapien 3 had lower complication rates. But there are important concerns that may impact the results compared to tricuspids. The durability question is going to be different. If it's elliptical, and bulky calcium, maybe have less durability. And then you also have to understand what you're going to deal with the aortopathy in these patients. That doesn't mean you can't do it. This is an example of a bicuspid that we did. But we do these patients asleep. You see on the balloon expansion, this echo here goes relatively circular, so we had less concerns. We did a balloon expandable Sapien XT valve at the time. With a good result. We've done bicuspids with core valve, with Sapien, but we generally do it in higher risk patients. In a 75-year-old that's truly intermediate risk and a type 1 bicuspid with heavy calcium, we don't do TAVR, we recommend surgery for that patient. And lastly, the expanding indication with trials that are going on are settings where surgery doesn't make sense. We've always done TAVR to try and replace surgery, but there are settings where surgery doesn't make sense, but TAVR may make sense. These include asymptomatic patients or maybe patients with moderate AS. And the reason why TAVR can go where surgery does not is TAVR is different from surgery. It's less invasive, there's less procedural mortality and less comorbidity with the procedure. It's better tolerated in case of instability. It's a quicker recovery. And depending on which valve, you get a larger EOA with TAVR versus SAVR. And so one interesting trial that's ongoing to expand indications is the UNLOAD trial. So heart failure is the leading cause of hospitalizations, and it's characterized by increased afterload and sympathetic activity. It often has impaired LV systolic and diastolic dysfunction. Aortic stenosis is also characterized by increased afterload, except it's not at the vascular level, it's at the valvular level. And so we treat the heart failure with beta blockers, ACE inhibitors, other medical therapy. With aortic stenosis, when it's severe, we treat it with a valve replacement. When it's moderate, we watch. But the question is, if somebody has heart failure and moderate AS, is the afterload from that moderately stenosed valve significant enough that they may improve by fixing it? So the UNLOAD trial takes patients with an EF less than 50, moderate AS, and heart failure, and they're randomized between optimal medical therapy versus optimal medical therapy and TAVR with the SAPIEN 3 valve. The idea being that if you can get rid of that afterload from the valve, patients with heart failure will do better than if you don't. So we'll see what this trial results show. This will take another couple of years to enroll probably. The other population where we don't do surgery is asymptomatic AS. There's been multiple registries that have suggested that the asymptomatic AS is not so benign. This is a meta-analysis by Philippe Genereux, where published in JACC, where we're looking at 4 studies, a 3.5-fold increase in all-cause mortality with medical therapy in asymptomatic AS. So the early TAVR study is taking patients with asymptomatic AS, and they're randomized to the standard of care, which is watchful waiting and treatment when they become symptomatic, to treatment with TAVR while they're asymptomatic. So they get either a SAPIEN 3 while asymptomatic or conventional therapy. So we'll see again, maybe we should be treating these patients earlier. Those are all important questions. So these are several new indications where surgery is not. And beyond the existing indications we've already evolved into, such as valve-in-valve and lower risk populations, bicuspids, it's going to continue to evolve, but we have to collect rigorous long-term data. Thank you very much.
So I think we're being told that we're going to